From the heart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, I'm Bob Harrington from Weill Cornell Medicine, and I'm here at the heart.org and Medscape Cardiology on the floor, on the exhibit floor at the American College of Cardiology meeting in Atlanta. I love to use these opportunities at the big meetings to catch up with friends and colleagues, to talk about things that they're doing, things that might be of interest to the Medscape Cardiology listening audience. And I think we're going to have a terrific conversation for this one. We're going to explore the topic of food as medicine. And that topic has been talked about a lot on online. There's been some recent papers out on the topic. What exactly does it mean? How are people thinking about it? How are patients understanding it? And I can't imagine a better person to join me today than my friend Mitch Elkind. Mitch is the Chief Clinical Science Officer at the American Heart Association and is part of the large team at the American Heart Association working on a food is medicine project called Food is Healthcare.
Well, first of all, Bob, thank you so much for having me on the show today. So our initiative at the Heart Association is called Healthcare by Food, which is Healthcare X for the by, healthcarexfood.org. People can find info online.
Fantastic. So we're going to build to it, but I want to start broad.
Okay.
What's the concept of food as medicine?
So the concept of food as medicine is to provide nutritious food to people who have diet-related conditions. You know, we at the Heart Association, American College of Cardiology, lots of organizations have dietary guidelines, nutritional recommendations. We've been in the space for a long time, I think, of telling people what healthy foods are, what people should eat to prevent hypertension, diabetes, heart failure, and so forth. But food as medicine really goes a step further. It's all about actually providing that food, that healthy food, to people so that they can eat it and consume it and, try to prevent and manage cardiovascular and other conditions.
Making the assumption that if you do that, they will have better outcomes.
Correct.
And that's what we don't know yet.
That's what we don't really know yet. That's right. So the literature so far is limited and it's suggestive, but doesn't yet kind of prove the point. For example, the way we might want to prove it for a medication, that providing meals and groceries or produce to people works.
And as I understand it, having been involved with this with you through the Heart Association, part of the challenge is that food means a lot of things. There's the nutritional element to it. There's the social element to it. There's a cultural element to it. And how does one think about all of that and try to improve health outcomes? I mean, in some ways you could say, well, don't we know what we're supposed to eat? Hasn't the Heart Association talked about this for years? But in fact, there's still a lot we don't know, isn't there?
You're right. We know what the healthy and nutritious foods are for the most part. There's certainly more work that could be done in that area of nutrition. But for the most part, we know what people should be eating, and we put out those recommendations. But the problem is that people are essentially swimming upstream, right? It's very difficult in our modern world for people to easily consume the foods that are best for them. There's a lot of pressures against them in terms of the easy availability of unhealthy foods. They're more affordable and so forth. So that's where food as medicine would come in as a way to provide those healthy foods directly to people, especially people who are food or nutrition insecure, meaning they don't have that kind of access. But you're right. I think the term food as medicine is in some ways really a misnomer because food is not medicine. When we think of medicine, right, a pill that we might use, for heart failure, one of your 4 pillars of heart failure treatment.
It's more than that now, but that's okay.
Yeah, okay. I can't keep. I'm a neurologist, right? So I'm a little bit behind the cardiology space. The medications are intentionally designed and manufactured to be identical one pill to the next. You know the exact dose. You're giving it to a person in that same shape and form, regardless of their religion, their background, their cultural preferences, their personal tastes, and so forth. Food is the exact opposite of that. right? Food means what your family likes to eat, what your personal tastes and preferences are, maybe what allergies you have, what your religious affiliation is, what your background, what people eat in your neighborhood, your region of the country, all of these things. And so
what time of day you work and and building food around that.
Yeah. You take a medicine on your own in your bathroom or something, looking in the mirror.
Yeah.
But you eat food with your family, maybe with friends, an extended group of people. So it's a lot more complicated than medication for that reason. And that's one of the challenges, I think, in studying it and in proving that this kind of an approach works.
And then the other thing about medicine is, at least in cardiovascular medicine and neurology, we test them as a community. So you have a medicine that you think improves somebody's outcome with heart failure, and we do the randomized clinical trial of seeing if that medicine adds value to everything else that patient is doing. Food, that's been tried, and those are tough studies to do.
They're very tough studies to do, and the studies that have been done so far have been a bit mixed. And where the evidence is strongest, perhaps, is in kind of pre-post design. So, people have been under a certain kind of regimen, perhaps, and then a food as medicine intervention is introduced. Mm-hmm. By the way, when we're talking about food as medicine interventions, there are three general categories that people refer to: medically tailored meals, where a meal is delivered to the person's home. Patient goes home from the hospital with heart failure. They have a high risk of recidivism, getting readmitted within 30 days. And so you actually deliver 10 meals a week, let's say, to the person at home. By the way, we don't know what the right dose is for that. So it's, exactly opposite of medication. Should it be 10? If you give people 10 meals a week, what do they do the other half of the meals of the week? Are they eating even more unhealthily during the other time? So a lot of tricky issues there. But medically tailored meals, medically tailored groceries, where the groceries are delivered, and then people still have to cook it as opposed to a meal. And then produce prescriptions, where you essentially give people vouchers they can bring to the farmer's market or grocery store and get healthy fruits and vegetables.
Yeah, and the second two really allow people to put the food into their social context. Is that
it gives them more flexibility, but perhaps, that the question is whether people will use that as much or not. And so, as you say, there's been some randomized trials, but they've been limited. The randomized trials that exist tend to be small in size. They tend to use variable definitions of dose and duration and these other issues, how long it should go on for, 3 months, 6 months, longer than that. That obviously becomes expensive too. So there are a lot of issues that arise in the research that's been published. And so far, we haven't reached the level of, a high quality, rigorous randomized trial that would prove to and ensure that they should cover this the way they might cover medication.
Yeah, I was going to bring this up as the next point, that as a clinical researcher, clinical trialist, I became aware of this when Nancy Brown, the CEO of the Heart Association, told me we really need some, but I think she said, traditional trialists to take a look at this space and help us, the Heart Association, think about what would be the level of evidence to be in a guideline? What would be the level of evidence to convey to and ensure that this evidence is good enough to provide health benefits, so to show this providing health benefits, and you should cover it as part of your insurance plan? That's how you got involved.
That's how I got involved too, as a trialist. Also, not as a food expert, not as a nutrition expert, but as somebody who's done trials in the stroke space, you in the cardiology space, and thank you for being on our team at the Heart Association looking into this as well. But that's exactly right, that we were looking at how we could take that next step to provide high quality evidence. Now, I think you asked a good question about what kind of evidence will convince policymakers, let's say, the federal government, to cover this under traditional programs like Medicare, Medicaid, or private insurers.
Or us as a Heart Association and American College of Cardiology, put in our guideline.
But those may even be different kinds of questions. And so, in other words, the threshold for what one would consider adequate evidence, I think, might differ, between a professional society and, a payer, what they're going to want. And I think we don't really have a great answer to that question. Going back to this issue of how variable food as medicine is, there are all the different issues about the dose and duration and so forth. There's also many different conditions we're talking about. There's heart failure, which may be a prime example of where this could work. There's also hypertension, diabetes, and kind of the outpatient space for prevention. There's different populations like pregnancy and the postpartum state where we think this could have a big impact. There's children. We have an obesity epidemic among kids. So what can we do there? But immediately it becomes a lot of different trials. Yeah. You're going to need a lot of different studies in different groups of people, really trying to get the evidence, the best evidence we can in these different areas that will help policymakers and payers make these kinds of decisions. We're not looking for the one definitive class,
not like the stuff we've seen this morning,
like the stuff you presented today on Aegis 2 and so forth. I think this is really getting a massive data of different types that will inform us in making these kinds of decisions, because it's just that complex.
To use the phrase, the totality of the evidence. So what does that totality look like that makes people comfortable that this is a good thing to do, that as a society, this is what we should be investing in?
Precisely.
Talk about how the AHA got involved with this.
Yeah. So the American Heart Association's Healthcare by Food initiative is primarily focused on research. And it came about through conversations between the AHA CEO, Nancy Brown, and the CEO of the Rockefeller Foundation, Raj Shah. And they recognized that the Rockefeller Foundation has been interested in food as medicine for a long time, but they really wanted to go to that next level to get that kind of high-grade clinical trial evidence that would demonstrate to insurers the cost-effectiveness of these types of programs. And they recognize that the American Heart Association, thanks to leaders like you and others, has that kind of experience and expertise to conduct those trials. And so that was kind of the genesis of the initiative. And as we've built it, we've brought in other tremendous folks. And our leader is Kevin Volk, who is a general internist and behavioral economist with a PhD in economics from the Wharton School at the University of Pennsylvania, who's on faculty at the University of Pennsylvania now. He's been leading this initiative. Kevin has brought tremendous knowledge and insight into this whole process.
Because he's done some very interesting studies over the years, with his background in behavioral economics, of how one does influence behavior. Exactly. And he's done very rigorous randomized trials of looking at different behavior modifiers. And now he's being asked to put it to this task.
That's exactly right. So Kevin is also a trialist, but he does a different kind of trial. It's to, do you pay people to quit smoking? Can you pay people to exercise more? And so that has really inflected our approach to these kinds of trials. So we're not doing those huge, kind of definitive trials yet. What we're focusing on initially is addressing some of these initial behavioral types of questions so that when we do the big trials, we have the highest likelihood of succeeding. So we're trying to address questions around how you make sure doctors refer patients for food as medicine programs, how you get people to enroll in them, how do you ensure that they adhere to a regimen, that they fulfill their benefits, for example. Something I learned through doing this is that WIC, the Women, Infants, and Children's program, that's one of the most successful food as medicine programs that's out there currently, right? It turns out that only about 50% of the people, the moms, who are eligible for that benefit take advantage of it. There's literally billions of dollars left on the table not getting used. And so if you try to do a big program in a health insurance program or in Medicaid or Medicare, and half of the people aren't even using it, then it's not going to work. And so we're trying to address some of those questions. How do you make sure that people take those vouchers and go to the farmer's market and bring home the healthy food? How do you make sure
and then actually eat it?
And eat it. If a basket of, vegetables is delivered to the front door and people don't know how to cook it or use it, then that doesn't help either. So you have, and this goes back to what you were saying before, you have to include some coaching and nutritional education, culinary education, and so forth for people to take advantage of these.
I've been amazed at the diversity of expertise that this project has required, not just from, I'll call the science, research, policy community, because there's some amazing people working on this, but also from industry. Yeah. I mean, the people who deliver food as part of their business model. people who sell food. I was amazed that Kroger was interested in this. And I remember being at one of the first meetings at Rockefeller, and I was sitting next to somebody from Instacart, and I was sitting next to somebody from Apple, and I was sitting next to, around the corner on the table, from the CEO of Kroger. I mean, that's amazing.
Yeah.
That everybody wants to see this really evaluated properly.
Yeah, I think that's right. I think people are very excited by it, interested in it. And to your point, it really requires a lot of diverse stakeholders and expertise. And, the way the Heart Association goes about these things, the research is at the core, but it's surrounded by an envelope of other systems that are helping to facilitate this. Our advocacy team is involved, our patient communications team, our health equity team, communications and marketing. So all of these are going to play an important role, because if you get the science done and we prove this works, it doesn't do any good if it doesn't get implemented on the other side. And that's why, we have a very diverse team of experts, experts in cost effectiveness analysis, experts in implementation science, experts in behavioral science, other than Kevin, experts in user experience, technology, as you mentioned, is an important part. When you think about food being personalized for people because of all those issues we talked about, the different cultural factors involved in food, that means that you can't give the identical meal. You have to come up with different meal plans for different people.
Yeah.
And so potentially artificial intelligence and other technological advances can play a role in coming up with recipes that are attractive to people but provide the same nutritional value. So it's a very complex endeavor, but a lot of people going into it.
And you've learned a ton, obviously, being involved in this, as you say, because it's bringing in people and experiences that you and I don't ordinarily think about. And that part's been fun. What have you learned so far about this?
Well, so we have launched our initiative with a total of about 20 clinical trials that we've started. These are small pilot trials on the order of 18 months in duration to try to answer some of those early questions.
Just think about that. That's pretty amazing.
It's pretty amazing within the first year of this initiative to get 20 trials off the ground. Several of them have already started enrolling patients. And we don't have, the results from these studies yet, but that's accruing.
Give us an example of one or two of the trial questions that are being asked.
So some of the questions have to do with coaching, for example. What is the value of coaching on top of providing people with food? If you give people food for 3 months or 6 months and then you pull the plug, then what happens,
Yeah.
right? And so we're trying to come up with ways of providing that coaching. And one question is whether it should be done in person or virtually. With COVID and telehealth, obviously, we have the opportunity to do that. So is a telehealth approach or a virtual, online cooking class or something along those lines adequate, or is really individual attention important? I mentioned the issue of people fulfilling their benefits. So there's the question of whether we can increase the likelihood that people fulfill benefits by texting them regularly, for example. So simple intervention, but can we improve that? People have shown, for example, that texting increases vaccination rates,
Yes,
right?
I was going to bring that up.
Similar kind of approach to that.
And that's a very public health approach.
It's a very public health approach. It's a behavioral medicine approach. These are the kinds of things that Kevin has brought into this as well. His center is called the Nudge Center at Penn. So it's all about how do you nudge people towards healthy behaviors. We know what people should eat, going back to what you said. Look, we know what the nutrition is. We're not thinking so much about what is healthy. We got dietitians, we got nutritionists who can tell us what people should eat given their, health status.
Getting them to do it.
How do you get people to do that? So it's these nudges that we're working on. So those would just be some examples of how we do that.
This is fascinating. If people want to get involved, give the website again if they want to take a look.
Sure. So the website is Healthcare by Food. So it's healthcarexfood.org. We don't know for sure, but we expect there will be other opportunities for grant funding. So hopefully our research community will be involved. There are a lot of people who are cardiologists who do this kind of research already. This is a well-developed field.
Yeah.
There are companies out there that provide medically tailored meals. There are health systems that provide it for their, members. But the issue is that it's not yet proven to work And so it's not covered broadly. And I'll tell you one other thing, as a neurologist, right? This is not like my bread and butter, so to speak. It's food, but it's not my bread and butter.
You're not supposed to be eating bread and butter.
Yeah, exactly. My bread and olive oil, if you will. But when I think about what we're doing with food as medicine, it's about the behavioral economics, the behavioral science, and that, frankly, is decision neuroscience. So to me, I got into this because I joined the staff of the Heart Association, and this was a big initiative, and because I do clinical trials and so forth. But I see it also as a way to engage what we're doing at the Heart Association around brain health too, because to change behavior, we're talking brain health.
That's exactly right.
Yeah.
And what amazes me about this is the power of the Heart Association to be able to, as you said, have the core of research, but it's really everything that goes around it that few organizations can do. And it really does allow us with advocacy and all of the other pieces of the AHA to really think about being bold enough to launch this, first of all. So kudos, Mitch, to you and the team. It's a terrific idea. This has been a fabulous conversation. I hope you've enjoyed it. Food is medicine. And I've been here with Mitch Elkind, the Chief Clinical Science Officer from the American Heart Association. And check out the website, see how you might be able to get involved from the research community perspective. Mitch, thanks for joining us.
Bob, thank you so much for having me.